Well, good morning. It's my pleasure to be here, and that was a wonderful introduction of the anatomy. I've just spent the last 2 hours next door with the scientists, the immunologists, and the geneticists, hearing about what the latest is and the details of the molecules of the immune system and the nervous system and how they interact. And so I hope this morning to actually convey in more logical terms what they're talking about there to you all, and so that we can translate some of this information back and forth in the spirit of the meeting. So much of what I do, is, as Carlos said, is study multiple sclerosis, but many of the things that happen in MS are very similar to what happens in TM and some of the other rare neuroimmunologic disorders that we're discussing. So I'd like to use MS in many cases here as an example. We're going to talk a little bit about the how, what, and why of MS. What are the immune cells? Who are the players here that you hear about, the T cells and the B cells and the macrophages? We're going to talk about some of the cytokines, which are the, if you will, it's like a hormone or it's a substance that's released into the blood or spinal fluid to allow the immune cells to communicate with each other. We're going to talk about how T cells and other cells become activated, mechanisms for why this whole autoimmune process happens in some people and not other people. We're going to talk a little bit again specifically about stages of the MS lesion and different pathological variants and what we can learn from that, because everyone presents slightly differently. It's almost as if this isn't one disease process. Even with TM or MS, we see lots of different variants, and we're now starting to understand that at a pathological level. And then we need to bridge back and forth between what we see under the microscope and what Dr. Pardo does pathologically and what we see with our patients, and try to learn lessons that will help us devise better therapies for different subtypes of these diseases. So with all autoimmune diseases, in fact, with many medical illnesses in general, there's an interplay of many different factors. It's the genes, or what we're born with, who we are, that make us individuals. And I always kid people that, unfortunately, scientists spend a lot of time studying clones of cells or strains of mice that are virtually identical in the laboratory, and what we find in the laboratory doesn't always translate into what happens in the clinic, and that's because we're very different. We all have slightly different variations of our genes. And then the environment's different. Some of us were raised in equatorial regions, some raised in far northern latitudes. We get exposed to different viruses, different amounts of the virus at different times in our lives. And that may dictate, depending on what genes you have, how you respond to the virus. And so this is where the immune system comes in. And there's an interplay here of all these factors that probably determines the different subtypes of these diseases. So you're going to hear more about MS a little bit later from Dr. Bowen, so I don't want to steal all of his thunder, but again, MS is a nice example because we know it's a disease that has a genetic predisposition and an environmental component, and immune factors play into it. We see pathologically and on the MRI evidence for inflammation, damage to the myelin, same as in TM, and then ultimately, if this process is vigorous enough or lasts long enough, we see damage to the underlying nerve wires, the axon fiber bundles that carry the signals from the brain down to the spinal cord, and the sensory ones that go back up again. And so this word pathogenesis, fancy word for how does it happen? Well, one of the prevailing theories in many of these autoimmune diseases is that there's some kind of infection. This is the environmental trigger. That through a process that we call molecular mimicry, or it's better thought of as mistaken identity, if you will, the immune system fights off the infection and then goes around looking for things that look like that infection. And if the infection is appropriately cleared, sometimes the immune system in people who have autoimmune disease does not turn off properly, and it will try to find something that looks a little bit like that infection. And we know that there are things in the nervous system that actually have sequences of amino acids that are very similar to some of the common infections that we all get exposed to. And so one possibility is that we all get exposed to the monovirus, the Epstein-Barr virus, but some people don't turn off their response to it. And so then their T cells go around looking for things that look like that virus, and it turns out that there are fragments of myelin proteins that actually look a lot like that virus, and those T cells may go in and attack the myelin. There are other mechanisms that we'll also talk about in a little bit more detail. And then we know that modulating the immune system, if we catch it early, is very effective in treating this disease. But if the damage to the axons occurs, then we need to think about other factors, maybe repairing, restoring myelin, or providing things to keep the underlying nerve and the axon happy and functioning. And as we move forward during this meeting, we'll talk a little bit later about therapies. So this is the worldwide prevalence of MS, slightly old map, but again, there are these geographic differences which can be interpreted in two ways. It could be changes in genetic pools, so we know that MS is common in northern European populations and in northern parts of this country, as well as down in southern Australia and New Zealand. And of course, these are common migration patterns. People from the UK have migrated to both places, as well as northern Europeans here. But there may also be commonalities in environmental exposure, so that we know in damp, cold places like Baltimore in the winter and the West Coast, Seattle, in the UK, that we see a lot of MS, and so that maybe it's exposure to viruses that are prevalent in these regions that are not prevalent in the equatorial regions that may increase the risk. When we look at the brains of these patients, we see areas of sclerotic plaques. And in fact, the disease was described pathologically over 100 years ago by a French neurologist, Charcot, who described the les scléroses en plaques, and basically these hardened, grayish areas. But we know that the acute lesions are actually more inflamed. They can actually look reddish, and there are swollen blood vessels. So how does it happen? Well, the immune cells that are in your blood that are normally there to fight off infections actually somehow get into the nervous system. This is a blood vessel, and these are red blood cells, and we're seeing white blood cells, which are part of the immune system that are designed to fight off infection, somehow are getting out of the blood vessel, going into areas around the blood vessel. In this case, this is brain tissue, and are recognizing something there that they think they're supposed to be attacking or responding to. Again, perhaps they were thinking that they're finding monovirus in the brain, and what they're really seeing are these myelin proteins that look like that virus. The immune cells in your brain start causing damage. They release cytokines, these communicating molecules that send activation signals to other cells. Some of them are directly damaging themselves. And cause, here the blue is a myelin stain. Normally we have a nice blue pattern throughout the white matter. And here we can see a focal area where the myelin has been chewed up, and here is partially repaired myelin, but not fully repaired. And as I said, the underlying nerve fibers become unhappy after this immune attack. So we can see some of these nerves have actually balled up, and we can imagine if you cut a rope, or a rope is frayed at the end, you'll see the little fiber bundle sort of end up in a little ball, and this is what happens in these inflammatory lesions. We see this in MS, we see it in TM, and it's been described in other disease processes. So again, an axon losing some of its myelin and then balling up into these little, what we call spheroids. So just a little bit of more background about the immune system. Of course, our immune system is there to protect ourselves from infections, bacteria, viruses, parasites, fungi, and it protects through two arms. There's what's called innate immunity and adaptive immunity. And innate immunity is we're born with some cells that can just respond to infections immediately. They don't have to be trained or taught to do anything. They're as scavenger cells, and they can naturally kill some of the invading organisms, and that's sort of your first wall of defense. Then there's a second arm that we'll talk about a little bit more, which is what we think becomes more activated in these autoimmune diseases. So after your innate immune system either fails or the infection persists, then this part gets turned on. So what are the parts of the adaptive immune response? Well, it requires exposure to the infection to stimulate the immune system, and usually it's a more prolonged exposure. And there are cells of the immune system, the lymphocytes, which are the first guard, if you will, of the adaptive immune response. And so we call these different things CD4 and CD8 with the T cells. And CD8 T cells actually are sometimes called killer cells or cytotoxic T cells, because they release things that actually can kill other cells or infected cells, and this is an important function naturally in fighting off infections such as viruses, but when the immune system is tricked and these CD8 cells get into the brain, they actually can cause damage. We also have an arm of the T cells that are called CD4, and these are helper cells because they actually activate the CD8 cells. They also can activate the next part of our immune system here, the humoral immune system of the B cells. And so you hear people talk a lot about these different lymphocytes, and many people are interested in trying to target them specifically from getting into the nervous system. And one of the therapies that's showing a lot of promise that maybe the next approved drug for MS is a drug called natalizumab or Antegrin, which targets a surface receptor on some of the T cells and prevents them from getting into the nervous system and causing this damage. What's called the humoral immune system, I put the Th2 type of cell here because this is a helper cell that actually has been implicated in providing help to B lymphocyte growth, and B lymphocytes are the ones that start making what are called immunoglobulins or antibodies. And antibodies are released, they're proteins that are released from these cells and can bind to different things, and they can help the immune system then attack and kill a specific other cell. But in the case of these inflammatory autoimmune conditions, the antibodies bind to proteins, normal cell proteins like myelin or even perhaps the nerve fibers themselves, and can cause damage through activation of some other proteins. So that there's a whole cascade of events here that becomes fairly complicated and sophisticated that people spend their whole careers trying to tease apart little surface receptors on these cells to try to ask questions about, well, what is it doing at this stage of MS, or what is it doing at this stage of transverse myelitis, and can we find something on the blood cells that will tell us that they're programmed to be going into the nervous system, and so we can maybe prevent it from happening or prevent another attack from happening. So many people actually study how these cells grow up, and I just wanted to share with you a little bit what we know about this. So cells of the immune system begin in the bone marrow. We have stem cells in the bone marrow that are specifically designed to make new blood cells. They make red blood cells and they make white blood cells, and then they're precursors to all the subtypes we've been talking about. So T cells come out, there's a precursor that comes out of the bone marrow, goes to what's called the thymus gland in the neck, and the thymus is where those T cells are actually educated, if you will. B cells actually mature in the bone marrow but come out and go to lymph nodes and undergo further maturational process. And so that the commonality here is both these cells end up in your lymph nodes, whether it be in your neck, under your arms. You have lymph nodes all over your body that are constantly responding to these different foreign invaders. So this is my little cartoon. You have the bone marrow prep school here. They come out, they go to the Thymus University where they learn what they're supposed to respond to. And so a lot of people, immunologists, study the thymus because maybe this is where the problem is. Maybe that it was a bad education. They just didn't go to the right school, right? But seriously, the thymus is actually where what is called a selection process occurs, so that the T cells are exposed to different antigens, self-proteins, and foreign antigens. And basically what you want is you want a repertoire of T cells that could respond to basically anything that you might see. So we have thousands and thousands of different T cells with little recognition molecules, we call it T cell receptor, that allow us to respond to all sorts of different infections. And then some of those T cells actually also respond to cell proteins, but the thymus is pretty clever and limits the number of those cells. But it turns out that we all have a small number of what we call autoreactive T cells coming out of our thymuses. So why is that? Well, it may have been Mother Nature's clever way of allowing us a way to get into parts of the body where those T cells normally shouldn't go, but under extreme circumstances it might be beneficial. So normally we don't get brain infections, and we don't want a lot of cells going to the brain. But it might be useful to have a few T cells that actually do recognize some of the things that are in the brain, the myelin and the axons. And unfortunately, in the cases of infection, some of those T cells may become expanded abnormally and start causing disease processes. But it's important that we understand why we have these cells and how we can keep them regulated, or sometimes people call tolerant so that they're not attacking. They're just there as surveillance cells, if you will. They go in, they look around, see if there's any problem, and if there's no infection or activation or what some people call a danger signal, that they will actually leave the brain and go back out to the immune system. And it's in the peripheral immune system where this little T cell is going, where the action happens in the lymph nodes. And so we know that these foreign proteins get brought to the lymph nodes. Your lymph nodes sort of trap them. There are scavenger cells called macrophages that pick up foreign proteins and bring it to the lymph node and present it to the T cell. And if one T cell comes along and says, ha, that's the one that I'm really supposed to be responding to, that's my mission in life, it goes off and it attacks that protein. And in some cases, as I said, some of those T cells are actually programmed to go into the brain. So how T cells become activated, a lot of people study this. There are different signals that occur, and the little protein, which is depicted in green here, has to get presented by surface molecules on the macrophages, and the T cell recognizes it in the context of its little T cell receptor that I told you about. And then there are other communicating molecules, and there's an initial activation process. And then in autoimmune diseases, we think that a marker of the cells might be chronic activation, so chronic stimulation and differentiation into a different cell type that has a different set of surface receptors. And so we're now getting to the point where we can take blood cells out, and we just heard some beautiful talks next door where we can take cells right out of patients with MS or some of these other diseases and see differences of their surface receptors that allow us to say which of the thousands and thousands of white blood cells are the ones that are being chronically activated. And so, although we may not know quite yet which are the actual antigens they're responding to, we've narrowed it down from hundreds of thousands of cells to maybe 1,000 or so cells that look like they're abnormal in some of these diseases. And of course, that's really where we need to be going, because we need to have targets on them. If you imagine all these T cells, you want to find the ones maybe with the red hats, and the red-hatted ones turn out that they're probably 1 in 10,000. And so some of the sophisticated equipment that we have in our laboratories, we can pull out that 1 in 10,000 cell, and then we can devise strategies to target it specifically. And that's really where the whole field of immunology is headed. Another approach would be, okay, well, if we can't actually find the specific T cell that's sort of initiating this process, maybe we can block some of the communicating cytokines that are released by these cells. So I told you about the Th1 type of cell and Th2 cells, and these are all different cytokines that are released by these different cell types, and they provide different functions. And in MS, we think that the Th1 cytokines, interferon gamma and tumor necrosis factor, are the bad guys. In transverse myelitis, it may be different. Some studies suggest that the Th1 cells, like in MS, are bad, but in very acute diseases, or depending on what infection one's responding to, we just heard some data next door that you can get Th2 responses in some of these very hyperacute or very immediate attacks on the nervous system. And so that's really important, because some of the strategies in MS to block these cytokines may actually not work in those situations. Some of the Th2-mediated diseases also may have an antibody component, and so by just blocking the cytokines, that might not be enough. We may need to do a blood washing procedure that some of you are familiar with called plasma exchange, that pulls out some of the antibody proteins that are circulating in the blood of people who have this kind of presentation. So this is a very busy cartoon just to try to put it all together, orient you a little bit. So what we're trying to depict here are cells flowing in a bloodstream or in the blood vessel. These cells are the blood vessel wall that makes up what we call the blood-brain barrier. And then cells that get to the other side, or in the brain or spinal cord, cause a whole series of activation events that activate other cells that can chew up the myelin around the nerve and cause the nerve to lose its myelin or break up itself. And so as immunologists, we're constantly looking for these different targets. And as I told you, we're looking for targets directly on the T cell. We're looking for some of the receptors that allow it to stick to the blood vessel wall, and we look to block the cytokines. But it's really important that we find out which are the bad guys in that specific disease process, and how much does it differ between one person and another. And again, this common theme of variability in the response is going to be absolutely critical as we try to tailor our therapies towards the specific subtypes of the disease. So I told you about molecular mimicry, and this is the case of mistaken identity between viruses and normal self-proteins. How else can infections or the environment activate our immune system? Well, again, next door we heard about something called superantigens. So it turns out that there's some infections that release substances that activate immune cells in a non-specific, either direct or indirect manner. And a good example of this is either food poisoning or toxic shock syndrome. And in those cases, we get exposed to bacteria or sometimes viruses that release substances called superantigens that can bind to the T cell and just activate it. And so remember I told you that we all have these sort of low level of autoreactive T cells that are supposed to be just there undergoing surveillance. Well, if you get a bad infection, a bacterial infection that like toxic shock and get release of these superantigens, it's thought, and it's been shown in some models and now in isolated clinical cases, that those infections can activate your autoimmune cells to go in and cause some damage. Now, you would think that once the infection is cleared, that process would turn off, and that may well be. So that may be why we see some neurologic diseases that are just one-time episodes where it doesn't relapse and remit the way MS is. So we know that in transverse myelitis that for most people it's a one-time episode. But if we could identify who has those superantigens early on, we might be able to limit the damage. So the process doesn't just occur like a stroke within an hour. It probably occurs over a few days to weeks. And one of the talks next door was on identifying superantigens early in the intensive care unit setting and trying to devise drugs that might block this superantigen activation and limit the amount of inflammatory damage right when the patient's coming in with their presentation. And so that's actually really exciting, interesting, and important research. How else? Well, inflammation causes release of cell proteins. So normally, most of your brain proteins are isolated in your brain. We don't have a lot of fragments of our brain in other places, which is a good thing. But when you get an infection, sometimes those proteins get released and they drain into the lymph nodes in the back of your neck, and then the immune system has more exposure to them. Or sometimes proteins in the myelin sheath that aren't exposed because they're all wrapped up tightly, when that myelin sheath gets disrupted from a one-time event, and some people even think that a traumatic event can cause release of self-proteins that normally are on the inside of the myelin sheath and your immune system is not seeing them. Suddenly it sees them and says, uh-oh, danger, this is something wrong, thinks it might be an infection and starts attacking it. So inflammation and damage of tissues can cause release of these self-proteins. And then a final mechanism that has been shown in some diseases is actually direct infection of the lymphocyte, either the T lymphocyte or the B lymphocyte. So we know in one of the diseases that causes a spinal cord disorder mediated by a retrovirus called HTLV1, that virus can infect the T cells, and it causes those T cells to just start dividing rapidly and making their own cytokines. And so the virus itself activates the cells. And it turns out that in other viral infections, like the monovirus EBV, that can get into your B cells and cause the B cells to do funny things and divide and release cytokines. So direct infection may be something that happens as well. I'm not going to really have time to go into the role of some of these other things, but genetic susceptibility is absolutely critical. We need to be doing wide screening of people to try to understand what are the molecules that predispose people to these aberrant responses. We need to understand why a lot of autoimmune diseases are more common in women. What's the role of hormones? So in MS, the disease becomes quiet in pregnancy and then exacerbates postpartum. But in lupus, the disease is aggravated during pregnancy and is actually better afterwards. So it turns out that may be a shift of these Th1, Th2 cytokines driven by some of the female hormones like estriol. We need to understand that better. And I've already told you a little bit about this release of antigen from infections. It turns out that there's programming of cells to go to specific sites of the body. So some of you may say, well, okay, this is all well and good. We get infections. Some people are susceptible to it. But why did my grandmother get rheumatoid arthritis, and why do I have MS? Well, maybe there is a gene or a set of genes that predisposes to autoimmunity, but there are other things that then tell the cells to go to the joints in rheumatoid arthritis, or go to the gut in Crohn's disease, or go to the pancreas in diabetes, and go to the nervous system in MS and TM. So we're trying to understand the combination code for entry into different tissues, skin, the mucosa of the gut, or the brain. And although there turns out that there probably are not specific codes, that there are patterns that do define the sites of migration. And so just like a key, it's not going to be one notch, but it's going to be a very complicated pattern that tells a cell, you need to go to this specific site. The cells migrate across the nervous system. There are all sorts of signals. We're interested in chemokines, which is a kind of cytokine that basically sends out a signal and says, hey guys, come over here, this is where the action is, and maybe blocking those will be an important therapy. And as I said, there are different responses to this inflammation. So in MS, we recognize 4 different types of pathologies now that actually really determine what happens to the patients in many ways. So one of the great distinctions between 1 and 2 and 3 and 4 pathology is that the myelin-making cells that we call oligodendrocytes die in type 3 and 4, and there's very little remyelination. This is something we've recognized clinically. Some people have attacks and recover well, and other people don't. Now we're starting to understand this on a pathological basis. But again, what we really need to do is go back to the clinic and try to figure that out before we're at the point where we're looking at the tissue under a microscope. So we need to understand the subtypes of disease. There's a need to measure disease activity, not in the tissues, but perhaps using blood samples, spinal fluid samples, or MRI. And so I'd like to just briefly end talking about that. Stages of MS are also important, so that we know that some of the inflammation happens early. We see relapses, we see an active disease on the MRI. But the MRI tells us that in a late stage of MS, there's more degeneration of the nerves and the nerve wires. Disability gets worse during this stage, and there's a different sequence of events on the MRI. So the MRI is a window into the brain and spinal cord, and does give us very interesting, important information about how we might treat, because when there's a lot of inflammation, we might want to focus our treatments on suppressing that. In the later stages where the inflammation is less and there's more tissue damage, we might want to focus on restoring nerve function. I think for the sake of time, to skip over this. These are sort of some of the beautiful pictures that we can now get. We can see areas of demyelination in the deep parts of the brain. And we can see areas where when we give a dye called gadolinium, those lesions enhance, just like the ones in the spinal cord that you may have seen in transverse myelitis. The demyelinating inflammatory lesions in the brain enhance. So we know these are very active lesions, and we should be targeting the inflammation here. But remember, in this case, those cells are already in the brain, so we need something that will actually get into the brain to help stop them. And we know that in this stage of the disease, sometimes when there are these darkened areas of scar tissue, that the nerve fibers have dropped out. And so we need to, as I said, think about when we start to see these, think about, okay, this person needs a neuroprotective therapy to keep their nerve cells happy so they don't start dying out like in the very dark area there. And so really the whole field of autoimmunity we need to be thinking about the stage of disease, the type of disease, and combinations of therapy, because these things aren't just stage 1, stage 2. There's a series of events that happen slowly. And in fact, we know, although I told you inflammation happens early in MS, the axon damage ensues afterwards, you can actually see some axon damage right at the first time. So we need to target the immune system. We need to target protecting the nervous system simultaneously. So in summary, MS and many of these other diseases that we're studying are inflammatory and what we call degenerative, so that the nerves become unhappy and die. They're different kinds. The future is in diagnostic testing to better classify subtypes of disease using blood, spinal fluid, and MRI. And I'm very hopeful and optimistic that we're headed towards a time where we can tailor our therapies to the subtypes of disease and the stage of disease. And I think we're actually already starting to do that right now. So I thank you for your attention, and I'll pause for any questions.